Today, what I'd like to do is initially discuss multiple sclerosis, and we're going to talk about the MR diagnosis and information about the disease from MR, and including in the discussion will be the use of certain techniques to elucidate a better understanding of the disease. Then we'll discuss the differential diagnosis of multiple sclerosis, and lastly, we'll turn to other white matter diseases by etiology. MS is a disease of young and middle-aged individuals. It is the most frequently encountered disease that the radiologist will see and be able to help aid in making the diagnosis as well as in providing a differential diagnosis. Indeed, neurologists in the Annals of Neurology in 2001 suggested the importance of MRI and provided criteria to solely make the diagnosis of MS. And this was produced to enable patients to enter clinical trials at an earlier time interval. I think there are many problems with these stated criteria, and they have just recently been refined and are published in the Annals, I believe, in November. The bottom line, in my opinion, for radiologists are that these criteria alone put the radiologists on very thin ice. And I still, as a neuroradiologist, believe that the diagnosis of MS is a clinical diagnosis. The spectrum of pathology includes perivenous inflammatory cuffing, lipid-laden macrophages stripping myelin. There is clearly evidence of both demyelination and remyelination, and chronic MS not only has myelin loss, but also has axonal loss, and I'll discuss that momentarily. The MR findings include iso to hypo-intense lesions on T1-weighted images, high signal intensity on T2-weighted images. Enhancement is approximately 2 to 8 weeks, and the enhancement pattern could be in nodules, arcs, rings, or along cranial nerves. MS can involve the cortex and the deep gray matter, and it has a propensity for certain locations, including the periventricular region, the corpus callosum, the subcortical region, the visual pathway, and the cervical spinal cord. Occasionally, MS lesions present a diagnostic dilemma as they can look like tumors, and this has been termed tumefactive multiple sclerosis. Here's an example of a T1 hypo-intense lesion, which turns out to probably be what's termed in pathology a shadow plaque, and there's evidence of insufficient remyelination as well as demyelination in these lesions. And they are, contrary to what's been written, they contain some activity. Periventricular lesions of high signal intensity are noted on proton density T2 and flare. Here you can see them on the flare. With respect to enhancement, here is an arc, a nodule, and a ring. Cortical lesions, U-fiber lesions. So the U-fiber lesions turn out to be quite specific for MS and not seen in arteriosclerotic disease. Ring lesions, MS can demonstrate ring enhancement, and here's one tumefactive lesion. MS lesions may have a morphology that is ovoid, and this is related to the fact, and here's a nice ovoid appearance, to the fact that there is perivenous inflammation, and it occurs around medullary veins, and that produces this characteristic appearance, which pathologically has been termed Dawson's finger. What's interesting, as you increase your resolving power, and you can increase your resolving power by going to higher fields or by changing MR parameters. So here's an example of a 3T high resolution 512 by 512 image, and what we have seen, and this was reported by Guy and AJNR this past year, is this tail of inflammation, this widening of the perivenous space that projects radially outward. And this is at 3 Tesla. And we think this is more specific for multiple sclerosis than secondary demyelinating diseases. When you go up to 8 Tesla, you can see a lot more cortical plaques than you could ever see at 3 Tesla and 1.5 Tesla. So I believe they're actually much more apparent, and they explain some issues in the signs and symptoms of multiple sclerosis, but they are not apparent at 1.5 and hard to see at 3T. And here you can see what's interesting is they also, if you cut them in cross-section, you can see the medullary veins containing deoxyhemoglobin and the surrounding inflammation. Tumefactive MS. So tumefactive, how do you differentiate what it looks like where MS has the appearance of a tumor from a glioma? So in terms of imaging, you want to look for other non-contiguous lesions in the brain and clearly in the spinal cord. And if you see a lesion in the brain in a patient of the appropriate age that you think could be a tumor, but in the back of your mind can't rule out MS, look at the spinal cord clearly and look throughout the brain. In MS, there tends to be an incomplete ring of enhancement. It's termed a horseshoe appearance. Perfusion is increased in gliomas and not usually in MS. And Sumi Cha and Glenn Johnson noted that you can actually, on a perfusion image, you can actually see veins crossing through an MS lesion. And I'll show an example of this. Here's a perfusion image, and you can see these large veins coursing through a tumefactive lesion. MS can produce neural enhancement, and the common nerve, you know, is the optic nerve. But in addition, here's an example of enhancement along the 5th nerve and enhancement in the 3rd nerve. It has a propensity for certain regions, as I remembered, and one is the callosal septal interface. And here are flare images, sagittal flare images demonstrating MS lesions. And this this region is particularly resistant to hypertensive changes. In terms of the spinal cord, you can see isolated MS in 5 to 24% of cases. Most of the time, in the spinal cord, most of the time it involves the cervical region. These lesions tend not to involve the entire cross-sectional area. They tend to be peripheral, which distinguishes them from vascular lesions. They are characteristically less than 2 vertebral body segments in length, and that's very important when you distinguish that from the differential diagnosis of other lesions causing spinal symptoms. So here's a typical example of MS, peripheral, less than 2 vertebral body segments in length. Devic Syndrome is a specific spinal syndrome. It's associated with, it's a transverse myelitis associated with optic neuritis, which may or may not be due to MS. And there are other etiologies of Devic, including virus, TB, lupus. To be Devic, you really cannot have other brain lesions and have to have lesions of the optic nerve and spinal cord. So here is a Devic, and you can see the spinal cord is involved. It's a little peripheral going central, and you can see evidence of the optic nerve involvement without any lesions in the brain. I want to turn to 3 concepts regarding multiple sclerosis. One is the occult lesion in MS, which is diffuse. The second, which I alluded to earlier, is the fact that MS is more than just a white matter disease. It's actually an axonal and neuronal disease, which is interesting. And the third is something that our group has recently been investigating, and that has to do with what we think is a perfusional abnormality in MS that potentially could be very important in its etiology and maybe even in its treatment. First point is, and it harks back to what I was mentioning on my second or third slide, the McDonald criteria. When you specify certain lesions, it's not good enough for radiologists because you have to talk about imaging parameters and field strength. And the concept of having normal white matter is a relative concept. And it really depends, as I said, on field strength and imaging parameters. And just to make a point, at 1.5 Tesla, you see a few lesions. At 4 Tesla, these lesions are obviously much better defined. And if you have different imaging parameters, including parallel imaging and do high resolution imaging, you're going to see more lesions. And so to set up criteria that you see it at 1.5 Tesla, really, they don't hold any weight at 3 Tesla, et cetera, and especially for what is potentially a diffuse disease. And this is another example of how you can appreciate the diffuse nature of MS. Here is a proton density weighted image of MS, and you may see a little lesion here or abnormality. If you use magnetization transfer to interrogate the white matter, and just by measuring the magnetization transfer values, you get all these are the pixels with normal magnetization transfer values, and then you ask the computer what's abnormal, and all of this jumps out. So there are fundamentally a lot of pixels here that are abnormal, despite the fact that we don't see them on a conventional image. And what it suggests, and what's important here, is that MS is truly a diffuse disease, and you're only seeing, in some ways, the tip of the iceberg. Second concept, MS is more than a white matter disease, and this was brought home, or rediscovered, I should say, by Trapp in 1998 in a very classic article using confocal microscopy, where he demonstrated axonal transections in acute MS lesions. And he noted that these axonal transections were common, that they were related to the degree of inflammation, and he hypothesized that they may be the pathologic correlate of irreversible neurologic impairment. Of course, just as a sidelight, I should mention that Charcot, in his original paper, had suggested this was more than a white matter disease. So it took over 100 years to rediscover that. But clearly it is, and clearly it's important. And this is a nice demonstration to show sort of the loss of axons. These are diffusion tensor images in an MS plaque and the normal appearing white matter, and you can see how you're losing your whole axon and white matter fiber in an MS lesion. MS also results in abnormal metabolism, and magnetic resonance spectroscopy can detect that. And I've just summarized the features of MRS. NAA, which is N-acetyl aspartate, is low, choline may be increased, creatine is decreased, and you may see lipid, lactate, and N-acetyl in some cases. This is an example of a heat map demonstrating in a patient the diffuse loss of NAA. So this is an NAA map, and the average loss here in the normal appearing white matter, so not detectable by conventional imaging, is approximately 20 to 30%. And here's another example demonstrating here is a lesion, and there is significant loss of NAA well beyond the lesion. So the abnormalities around MS lesions the borders are very fuzzy, as opposed to other lesions such as diffuse axonal injury. I want to just make one other point about MS, and that is we believe that there's significant vascular pathology, and we believe it's more on the venous side, where you see the perivenous inflammatory cuffing. and potentially evidence of hypoperfusion and maybe some increased perfusion. So we studied a number of different MS lesions, and we found that enhanced lesions obviously have increased perfusion. But non-enhancing lesions, some of them had hypoperfusion, and some of them had increased perfusion. And much of and actually the white matter, the normal appearing white matter had hypoperfusion as well, suggesting that there's a lot more going on at the vascular level than we've ever thought about. And associated with the abnormal perfusion in MS is that we found iron deposition. And we found iron deposition in the normal basal ganglia as well as in some lesions. And why does that occur? Well, there may be disruption of iron transport. So iron is normally taken up by the basal ganglia and then transported peripherally along the neurons. And potentially MS interrupts that transport. It also can be related to ischemia and hypoperfusion. And MS isn't the only disease it's seen in. It's obviously seen in Parkinson's disease and Huntington's disease. And what's the clinical significance of the iron deposition? Well, iron can produce tissue oxidative damage. And excessive iron could damage the oligodendroglea, which produce myelin, and may have a role in the pathogenesis. So this is very new and pretty exciting. And let me just show examples of it, because you can actually see it. So here are this is done by Yulin Gi in my laboratory. And here you can see multiple MS lesions, and these are susceptibility-weighted lesions at 3T, and you can see iron in many of these MS plaques. We also developed a technique, and this was done by Jens Jensen at NYU, to measure iron, and it's called magnetic field correlation, and I'm not going to go into that, but just to demonstrate that clearly there is abnormal iron deposition in the basal ganglia of MS patients. And here's an example. That is a heat map of an MFC image demonstrating high iron content in the basal ganglia in an MS patient compared to a control. And in this hypointense lesion, you can also see high signal intensity. So iron, I think, will play an increasing role and stick around for the perfusion study, the perfusion data. I want to now switch gears and discuss the differential diagnosis, the MR differential diagnosis of findings that are compatible with MS, and we're going to cover some of these diseases. Lyme disease. Lyme disease may occur in a very similar age population. It can present with neurologic symptoms not dissimilar to MS, including optic neuritis and facial nerve palsy. The vast majority of Lyme disease demonstrates normal scans. However, you can see a host of other findings, some of which can look exactly like MS. And I want to remind you, of course, that every MS patient thinks they have Lyme disease, and so they get worked up, and they should be worked up, but in the end, the vast majority of them have MS. It's much more common than CNS Lyme. So here's a hypointense lesion on T1 weighted images in a patient with Lyme disease, some increased high-intensity lesions. Actually, Lyme disease can produce inflammation in the leptomeninges, which multiple sclerosis does not do. Here you can see high signal intensity lesions in areas that would be most compatible with multiple sclerosis, and an enhancement pattern, which it's very unusual, but MS can produce enhancement Lyme disease can produce enhancement in the brain. Another mimic of MS is sarcoid. Now, sarcoid has a plethora of imaging patterns, some of which can look identical to MS, and sarcoid could produce an optic neuritis type picture. Here's an example of a pattern that really isn't compatible with MS, and that is enhancement and disease along the Virchow-Robin spaces. Here's another example of a recent case we had of a sarcoid which is producing a vasculitis with associated hemorrhage in the brain. Behçet's disease has, again, similar age group, potential for syndromes that are compatible with MS. And here's an example. Behçet's lesions tend to be more central, don't respect any anatomic boundaries, and can start in the midbrain and progress superiorly. And this is not an uncommon picture where edema and enhancement follow the internal capsule superiorly. So this has been reported as a common MR feature of Behçet's. Lupus. So lupus can present as a transverse myelitis, which can look like multiple sclerosis. An important differential between lupus and MS is that lupus generally involves the central gray matter and will involve 4 to 5 vertebral body segments instead of less than 2 vertebral body segments in length. Here's an example of lupus of the spinal cord, and you can see the extent of the lupus involved and the central pattern, which is an ischemic pattern as opposed to the peripheral pattern, which you see in MS. B12 deficiency can produce a myelopathy, and it also can present with paresthesias in the hands and feet and decreased vibratory sense, again, something that MS can clearly do. It exquisitely produces demyelination of the posterior and lateral spinal columns, and that differentiates it from MS. And here you see low signal intensity on T1 and high signal intensity on T2 in the posterior spinal columns. And that's clearly makes the diagnosis and separates it from MS of the spinal cord. Lastly, I would like to turn to demyelinating diseases characterized by their etiology. And these are the diseases we're going to discuss with the exception of trauma. Acute disseminated encephalomyelitis is a monophasic demyelinating disease, and it can affect the brain, the spinal cord, the cerebellum, the cerebrum. It's secondary to a allergic autoimmune cross-reaction, usually with a viral protein, and most importantly, the history suggests a recent viral infection or vaccination. And the viral infections that particularly do this are respiratory infections. So what happens is the patient has a respiratory tract infection, and then a week or so later develops a neurologic syndrome, and it could look exquisitely like multiple sclerosis from the clinical perspective, and it can produce a transverse myelitis, cranial nerve palsy, acute cerebellar problems in children, or optic neuritis. The diagnosis is made by history and spinal tap, and it could be a pretty potent disease with up to 30% mortality. In terms of the MR diagnosis, it could look for all the world like multiple sclerosis, as in this particular case. Diffusion was not, this is T2 shine through and not positive for diffusion. There's a little bit of enhancement. Basically here, in order to make the diagnosis, you really need to know the history. This is another case of ADEM, which doesn't look like multiple sclerosis, where you have a far more of a fulminant course, large lesions with mass effect and not much enhancement. At the worst end of the spectrum of ADEM is something called acute hemorrhagic leukoencephalitis, also termed Hirsch's disease. Now, this is a rare disease, and it's fulminant ADEM. It develops 3 to 14 days after a respiratory tract infection, and death occurs approximately 6 days after the onset of symptoms. It's a necrotizing angiitis. You see massive swelling, not a lot of enhancement, and the hemorrhages may be microscopic. And if you don't do susceptibility-weighted imaging, you could miss them. It spares the U fibers. So this is the only documented case that I have. It wasn't actually detected till after the patient died. What you see here is very significant involvement of the occipital region and massive swelling of the corpus callosum. Not a lot of enhancement, and at autopsy we found these ring sideroblastic hemorrhages. So it would have been wiser to have done gradient echo imaging. Progressive multifocal leukoencephalopathy is a demyelinating disease produced by the JC virus infecting the oligodendroglial cells. It's associated with the immunosuppressed state and clearly with HIV. It can involve the subcortical U fibers. You can have a whole host of different presentations. It's usually fatal over 6 months to a year. In terms of what PML can look like, it can really look like anything, and I'll show it momentarily. But contrary to what was originally appreciated, PML can have mass effect. PML may enhance, and it can affect the gray matter. Actually, Kim Nelson did some angiography on PML and found arteriovenous shunting with a parenchymal blush on if you end up ever doing that type of study. So here is an example of what look like very benign lesions. And the trick for the radiologist is when you see a benign looking lesion in an immunosuppressed patient, you better be thinking in the back of your head that this could be PML. So here are some lesions in the cerebellum, and here's a subcortical lesion, 1, 2, very benign looking, but this is PML. Here's a more fulminant case, and you can see confluent lesions, mass effect, the lesion going across the corpus callosum, necrotic PML in the brain, ring enhancement in PML, another mass-like lesion with a leading edge of enhancement. So PML can have any real configuration on MR, and it behooves you to know the history and all these non-specific white matter abnormalities in the immunosuppressed patient need to be taken very seriously, particularly if they're presenting with any neurologic problem. Okay, white matter hyperintensities, and this is the bane of the radiologist's existence. How do you deal with them? What do you call them? And I would argue, number one, I don't like giving a long differential and saying this could be compatible with da-da-da-da-da, because in the end it only gets you into trouble. And I would say these are of uncertain etiology if you really don't know what they are, and just truncate the discussion. It turns out that probably in 10% of patients up to 55 you see these, maybe even more, and 30% of healthy subjects over 60 have these white matter abnormalities, and the prevalence significantly increases with age, and the risk factors include women get them more than men, aortic atherosclerosis, and elevated systolic blood pressure. So those are the risk factors for developing these. And some authors have divided them into periventricular white matter around the lateral ventricles and deep white matter beyond the lateral ventricles. And there is a suggestion that the periventricular lesions may be associated with cognitive decline and the deep white matter with late onset of depression, but those relationships are tenuous in my opinion. Contrast that with ischemic white matter lesions which occur in the watershed or are involved by small penetrating arteries. Now, I want to make the point that there are vascular types of demyelination, and this group of diseases has been termed, was initially called Binswanger's disease, and is associated with a mental decline with poor judgment, memory and language and visual spatial impairment, and then a number of other signs and symptoms. And if you want to translate what Binswanger's disease may look like radiologically, it's this, which are patchy, irregular, periventricular white matter changes. CADASIL disease is another vascular type of demyelinating disease. It's recently become prominent. It's the term is for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's an inherited small artery vasculopathy. It occurs in the 4th decade of life, and it's associated with vascular events. And what you see are the extensive white matter changes in a young person who has the presentation of vascular events. And the Dutch group have noticed increased intensity in the subinsular region, and they think this is pretty specific for CADASIL. And these represent dilated perivascular spaces, and this was reported in Radiology a couple of years ago. Posterior reversible leukoencephalopathy, or PRES, represents a diverse group of high signal abnormalities that occur in most commonly in the occipital region, associated with a history of elevated blood pressure. So there are a whole group. This is a wastebasket term, and what probably this represents is the inability of the posterior circulation to auto-regulate when challenged with increased blood pressure. Here are some of the etiologies of this posterior reversible leukoencephalopathy, and they all look quite the same. And this is one example of posterior leukoencephalopathy from cyclosporine toxicity. You see the high signal. And this is ARA A. It looks the same, high signal. Take away the drug and treat the hypertension, and it gets better, and it looks normal. Postanoxic encephalopathy occurs after a hypoxic anoxic event. And what happens is the patient is resuscitated, and then there's an antigen response during the hypoxic period, and you get necrosis of the white matter, and diffusion is very positive. So here's an example of a patient who was resuscitated after a failed intubation, and a couple days later had a decline in mental status, and you see the high signal intensity in the white matter, the very positive diffusion, and the lack of enhancement. Osmotic demyelination is another iatrogenic problem secondary to too rapid correction of hyponatremia. And what you see is demyelination in the pons, and this has also been termed central pontine myelinolysis. You spare the periphery of the pons, the descending cortical spinal tract, but indeed the supratentorial region can be involved as well in osmotic demyelination. At the limit of osmotic demyelination is the toxic demyelination of the corpus callosum. It occurs in, it's termed Machia fava bignami, and you should think about it as well as thiamine deficiency in a sudden encephalopathy in alcoholics. Acute Machia fava has an enlarged corpus callosum. Diffusion is positive. And if you just see a very atrophic corpus callosum, you want to think of chronic Machia fava, and you want to think of alcoholics. Lastly, the purest demyelination that one sees routinely is from radiation. And here's an example of a patient who had a craniopharyngioma irradiated, unfortunately too exuberantly, and you can see the white matter change here significantly as well as radiation necrosis in the corpus callosum. So in summary, white matter diseases are amongst the most common diseases that you're going to encounter in the brain. MR has dramatically improved our ability, our diagnostic ability. And the importance is when you combine the history with the imaging findings, and I underline history, there's an excellent probability of making the correct diagnosis. And as I've tried to show, the new techniques really provide us with unique insights as well as diagnostic specificity. Thank you very much.